This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of this video or materials may only be undertaken with the prior written consent of the ARC. Copyright 2017, all rights reserved. My name is Timothy Myers. I'm a registered respiratory therapist and the Chief Business Officer at the ARC. I welcome you to today's presentation, the COPD National Action Plan. Where did it come from and what does it mean to respiratory therapists? Upon completion of this ARC webcast, participants will be able to review the current data regarding COPD and its impact on Americans and the American healthcare system, discuss the origins of the COPD National Action Plan and its creation, review the COPD National Action Plan goals and how respiratory therapists might integrate them into practice, encourage respiratory therapists to bring the COPD National Action Plan to their place of employment to educate them and create opportunities to use that. I am pleased to welcome Mr. Frank Salvatore. Mr. Salvatore is a registered respiratory therapist and fellow of the ARC. He is currently the administrator of ancillary services at Greater Hudson Valley Health System in Middletown, New York. He is very active with the ARC and is currently serving as the ARC's immediate past president along with many other roles. Mr. Salvatore has no relationships to disclose. I disclose that I am a paid employee of the ARC. Brand names of products and or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability. At this time, I'd like to recognize and welcome past President Salvatore. Welcome to the program, Frank, and take it away.
Thank you, Tim, and welcome everybody to this webcast. I hope by the end of this webcast you have a good understanding of the COPD and National Action Plan. And we hopefully, as respiratory therapists, should begin to integrate its use into our everyday. But before we get to the COPD National Action Plan, let's talk a little bit about stuff that we know. But when we start talking about the National Action Plan, we may want to use in making sure when we talk to others. So who has COPD? We know that 1 in 5 Americans has COPD, and we know that 16 million people are diagnosed. But what we also know is that almost as many millions of people may have it but not know it because they're not diagnosed. This is a disease that is more women than men at this point in time, and I have an interesting slide coming up in a couple to show you how it's affecting women, especially with death rates. And this is a disease that we all know this, and you know, it's always one of those things. It's a disease of smokers. But you know what? Yes, 38% are current smokers who have the disease. 37% are former, but you and I both know that in our daily practices, we're seeing more and more patients where their COPD is not associated with direct smoking. And right now, that percentage is about 25% of cases. Let's look at the scope of the issue when it comes to national. So in this field, if you remember, if you've been in this field for a while, you remember that at one point in time, COPD was the 4th leading cause of death in the United States. And we were all talking about the fact that it was the only leading cause of death that was on the rise. And we all said by 2020, it was going to become the 3rd leading cause of death. Well, if you look at this slide, I'm already listing it as the 3rd leading cause of death. And in 2012, we realized that it moved from 4th to 3rd. The big thing about COPD is it causes serious and long-term disability. And one of the things that is still remarkable is that this disease, not only 3rd leading cause of death, but it's the 4th leading cause of disability. This disease kills over 135,000 Americans each year. Now, I want to call your attention to the right of this slide. In 2010, they figured out that of the over 800,000 hospitalizations, the cost of COPD in the United States was nearly $50 billion. And of that, about $30 billion were direct healthcare costs. But then the rest were indirect mortality and morbidity costs. One of the things that we've all been dealing with in our practices is the readmission issue. You need to know that, they didn't sit down there in Washington, stick their finger in their mouth and wave it in the air to see which way the wind was blowing and say, you know what, COPD is going to be one of those readmission items we're going to look at. They had already had data that 17.6 of Medicare patients readmitted to the hospitals within 30 days of discharge had COPD. And those readmissions were avoidable in their mind, and it cost an additional $17.5 billion Medicare expenditures annually. So one of the things that we're dealing with is the fact that COPD is one of those readmission penalties that every single one of our hospitals is dealing with that as an issue. Let's talk a little bit about the challenges of COPD. I've gone to a lot of conferences, and although there are a lot of treatments available, they're not totally adequate to take care of the disease totally. And you can see the paradigm in increasing severity from self-education and smoking cessation all the way to surgery, where you may have lung reduction surgery, patients on oxygen, and you see the one in orange, the top one, pulmonary rehabilitation. I'm going to talk a little bit about that when we actually talk about the parts of the National Action Plan. But the thing that is staggering to me is the right side of this slide. I know it's kind of hard to see, but I wanted to get it into the presentation. You can see this is the age standardized death rates for COPD between 1999 and 2014. And those numbers are in 100,000. So it's the number of deaths per 100,000. The blue one is decreasing, and that's men. Okay. We always thought of this as a disease in men, and we probably paid a lot of attention to the men. But look at the red line. That's the women. Okay. Now, it's not appreciably increasing, but it's definitely not appreciably decreasing like the line for the men. And overall, when you look in the middle, the age standardized death rate for COPD, although it has a slight downward trend, it's not as significantly downward as in the men's death rate. So as a whole, the death rate is not changing. And it's something that we need to deal with, and we need to get the information out there, and we need to get more people to understand about COPD, and it's not just the patients. So based on all those statistics, and there's many more. I mean, I believe everybody on here is respiratory therapists, and so I'm preaching to the choir. But when you take all this together and you realize, somebody I know very near and dear to us in the AARC from the past used to say, and I believe also John Walsh used to say this, COPD is the Rodney Dangerfield of diseases. It gets no respect. Well, with the COPD National Action Plan, I believe we're going to finally give this disease respect. It is the first ever blueprint for a multifaceted, unified fight against the disease. Okay? Believe it or not, Congress asked the NIH and the COPD community to come up with this. So this was a request of Congress that this National Action Plan be put together. This plan does provide a comprehensive framework for action by those not only affected by the disease, but those who care about reducing its burden. So let's talk a little bit now about how this plan came about. And I'm looking at the list here of some of the people on the webcast, and some of you may have been involved with this. And I'm not going to go through a whole bunch of names, but there was a COPD town hall meeting which set the foundation for this plan. It was held in February 29th and March 1st in 2016. There were over 200 attendees. There were patients there. There were caregivers, healthcare providers. There were industry leaders, both from pharma and from DMEs. And 14 federal partners participated. Believe it or not, we actually had federal participation. The attendees were separated out into 6 breakout groups. And originally, there were 6 work groups that were put together, which led us to think that there might be 6 goals. But as you'll see, we got it down to 5 goals. Just so you can see, on the left, the 2 ugly mugs there. I don't think Keith Siegel is on this, so I can say it. He won't yell at me. Keith Siegel and I were your representatives of the AARC. Keith Siegel is the current Speaker of the House of Delegates, and at the time I was the president of the AARC. But what I want you to see is up in the upper right picture, and those of you that know me, yes, it's a Frank selfie. But everybody behind me, there was 1 or 2 patients, but a lot of those, if not all of them, are respiratory therapists. And you may notice someone in the picture that you know, but there was actually, these weren't all the respiratory therapists. There were more. So respiratory therapists were at the table for this, and that's why we're doing this today, because not only were we at the table, we want to get moving towards utilizing the National Action Plan. And down in the lower right-hand corner, you probably, those of you that are old enough probably recognize the gentleman to the right of me as Ted Koppel. His wife, Grace Ann Dorney-Koppel, was I believe she is or just the past president of the COPD Foundation, but she's one of those patient advocates that speaks loud and clear about the need for COPD to be dealt with from a patient perspective, and I was honored to actually get to be with them for this. When we got to Bethesda, we came about as working groups that looked at 6 different areas. Now, and I'm not going to read each one of these, but if you look at it, look at number 1, empower patients, their families, and communities. Prevent, detect, diagnose, and treat and manage, number 2. All the way down to number 6, integrate policy, educational program changes into the structure of the nation. Those 6 things were the highlights that the working groups had to work on. And from those 6 groups, the 5 goals as they stand today, as I'll show you in a little bit, came from these 6 working groups. Now, the working groups were tasked with identifying the target audience for each of the 6 goals, challenges and opportunities for each one of those goals that we were working on. And again, I'm using the word goals, but they're not going to be the same goals as we get towards the end here. Objectives. We were tasked with finding short-term objectives, which meant 1 to 5 years, and then long-term objectives looking out 5 to 10 years. We were tasked to look at strategies. How could we deal with the topic that we were working on, the goal that we're working on? And then they asked us to look for benchmarks. What benchmarks are we going to look for as a nation to say that we're meeting the goal? We looked at resources that were needed. And I'm going to show you Working Group 6, which I was a part of. This was a very difficult part of the project to determine the resources, not only the ones that were available, but ones that you needed to bring to the table. And as you'll see when we start talking about that Work Group 6, we needed the federal government at the table. In the end, each group had a group of implementers or leaders. And what had happened is, in this next slide I'm going to show you, and pardon the smallness of this chart, but in each group was asked to create leaders. The goal 4, which was actually the research group, and I've been working with some of you researchers out there. You all get involved to use the vernacular from my friends in the South. So they didn't really pick leaders. They all were going to be involved. But as you can see, goal 1 through goal 6, everybody had identified leaders. And if you look and you put your glasses on and you look real close, in goals 1 through 6, including the goal participants in goal 4, there are respiratory therapists all on those leaders who worked on those after we left Maryland. So as I said, I was part of work group 6, and I wanted to give you a little bit of a feel for where these came from. This was a tough work group because our work group goal was to integrate recommended policy, educational, and program changes into legislative, research, public health, and care delivery structures of the nation. Talk about a very large goal. You know, remember 2 years ago, although this year's not any better, Congress didn't do much, okay? We didn't have a lot of policy going through Congress, getting passed and get to the president's desk, and then you give a working group this task. It ends up being very difficult. And on this list, we had some really heavy hitters. We had, members from the COPD Foundation on here. We had people from the Lung Association. We had Rural Health Association, the Lung Association. I already said that. There was COPD Task Force, North Carolina. We had pharmaceutical here too, and we had home care representation, as well as your AARC was represented in this work group. So remember I showed you before, well, who's our audience? Well, look at this list. It's huge. I mean, this is one of those things that is going to take help from a lot of different areas. And I believe that even after we created this list, we felt that there probably was some more that we needed. So the objectives we came up with, we were looking for quality measures. We were looking for awareness and education about the disease to the policy holders, the policy makers. And then we were looking at stakeholder collaboration and awareness education. We're looking at legislative policy, funding, and appropriations. Yeah, imagine trying to find funding and appropriations from the national government. But yep, that was one of the things we're looking at. We're looking at improving the quality of life, and we're looking at integrating the other group goals. I think this here is where that last one, integration of the other group goals groups, that's where they kind of recognized that this was not a 6-goal outcome, that it was going to be a 5-goal outcome. The summary that we gave, the quick wins, short-term objectives, we needed to come up with quality measures, and we need to mobilize stakeholders, which meant we needed to find people in the government that were going to help out. So the audience, and here's one of the objectives written out. Strategic mobilization of stakeholders. That meant that our audience, we identified all stakeholders impacted by COPD who influence COPD outcomes. Challenges and opportunities. I mean, we put it in paper. Government ownership, building a platform of collaboration, consensus messaging, sustaining efforts, promoting urgency to act amongst all stake owners. Those are huge challenges. The opportunities. We were really impressed by the NIH's commitment to this session, and it worked out really well. So we wanted to find a way, how do we build on the NIH's commitment, and then leveraging financial penalties around COPD to build momentum and interest in the implementation of the COPD action plan. So one of the questions was, if we're going to penalize for readmissions, could we use that somehow to build something on the outside to get people to use the COPD action plan more? We can go through the rest of this, but this is how each group worked together to come up with goals and objectives. And then when we left Bethesda, we then gave everything back to the NIH, and they had a group of people that sat down and looked at all of our work. Okay, so the outcomes were that they engaged all the stakeholders in development of the content for the 6 goals to draft the COPD action plan. Well, you can see we already changed. It's not 6, it's 5. NHLBI and a group of participants prepared the draft of the action plan document. They posted up a draft of the action plan and asked for public comment, which was done. And the final version of the COPD National Action Plan, which you will see, it was published, and we're going to start following the progress of the goals. So if you want to put it in a timeline, believe it or not, this was led by a government agency. And look at the fact that within a year, okay, from May 16th, when they took what we did back in February and March, and they created the first draft of the action plan, solicited feedback in June 2016. They revised the action plan and resubmitted and submitted it for public comment. They reviewed over 200 comments, updated the action plan, and then by April 2017, it went that final review and design. So you're looking at a year and 2 months from creation to publication in May 2017. And that was an awesome thing to see happen quickly. So let's talk about the COPD National Action Plan goals. So from those 6 work groups came the 5 goals that you see today. Now, I want you to understand that, this is a national action plan that helps us to take all the different stakeholders and bring them into how to deal with the disease of COPD. This is not the GOLD guidelines. This is not asthma guidelines on how to treat. This is how to get COPD recognized, more people diagnosed, get people to understand about their disease, to live. This is all of that, okay? But it doesn't go into the specifics of the treatment of the disease. It goes into the specifics of how to talk about that stuff. So what are the goals? Number 1 is to empower people with COPD, their families, caregivers, to recognize and reduce the burden of COPD. I'm going to read through these because you're going to notice that in the next bunch of slides, we are going to go over each goal separately, okay? The second is to improve the diagnosis, prevention, treatment, and management of COPD by improving the quality of care delivered across the healthcare continuum. The third goal is to collect, analyze, report, and disseminate COPD-related public health data that drive change and track progress. The fourth goal is to increase and sustain research to better understand the prevention, pathogenesis, diagnosis, treatment, and management of COPD. And finally, the fifth goal, translate national policy, educational, and program recommendations into research and public health care actions. So those are the 5 goals. So let's talk about them. So goal 1 was to empower people with COPD, their families, and caregivers to recognize and reduce the burden of COPD. This is a very powerful goal. And on this slide, I have 5 areas of opportunities for engagement and participation. 1, we could share culturally and linguistically appropriate COPD risk assessment tools and educational materials with people with COPD and their families, friends, colleagues, and community members. That's one thing that we try to do well in our own hospitals. We try to make sure that we translate our tools that we use for our patients into different, different vernaculars. We need to work locally with stakeholders, partners, and communities disproportionately affected by COPD to support disease awareness. This means that we need to know our location. We need to know what the statistics are within our community for patients who have these diseases. And if we find areas of population who have disproportionately high levels of disease, that we try to work on those areas specifically to make sure that we deal with the patients directly. Organize and support local events and activities at hospitals during community events and activities, and as part of workplace wellness programs. Seek local earned media coverage and utilize existing health observances, including World COPD Day and National COPD Awareness Month. Well, I'll go over more of that on the next slide. Develop and execute train-the-trainer programs and distribute educational material at state and federal levels that have the unified messages and call to action. And finally, identify and engage new partners who can address COPD, particularly those with the ability to reach populations most affected by the disease, as well as those working on policies aimed at tobacco use prevention. So, what does that mean to us? Well, I took the liberty of trying to come up with ideas after I review each goal of how we could do this. You're going to see at the end that, healthcare workers may not be involved with all of the 5 goals. You could be a healthcare worker who's a researcher and be in a different portion of the goals. But this one is in our wheelhouse, okay? If you're an AARC member, you may have seen in a recent online article of how AARC members are implementing COPD National Action Plan that came out on August 21st of last month. There are people, and I don't know, I'm looking at the list. I don't know if I see the names on here, but there are some of our brethren that have done some very interesting things. And one of which a good friend out in Michigan, Mike Hess, has partnered with primary care offices to provide services and raise awareness and education to the patients in primary care office. These are all examples of how we can implement goal number 1. Well, how many know that in a mere month and a half, it's Respiratory Care Week? Respiratory Care Week comes October 22nd through 28th. Well, although it's a time to celebrate us as respiratory therapists, it's a perfect time to get out there and not only celebrate us as respiratory therapists, but highlight us as respiratory therapists. Taking the time to go do health fairs, talks at senior centers, Better Breathers groups, hold town hall meetings. I worked at a hospital that I made sure that every October or November, and you'll see why November in a second, we did a town hall meeting that was specific to COPD, because there were many people that came in from the community who not only wanted to learn about COPD, but we also did screening spirometry beforehand. We actually, after a couple of those town hall meetings, learned that we had to open up 2 hours early before the town hall meeting because the line got so long and overran us trying to use 2 spirometers. World COPD Day and National COPD Awareness Month occur in November, as well as the Great American Smokeout. So we have 2 months here where we could highlight COPD as a disease. And as I already mentioned, there are opportunities for us as respiratory therapists to extend our services into primary care offices. I know in my neck of the world, we have more urgent care centers popping up. I call them a doc in the box. Now, that was a big thing back in the 70s and 80s, but then they all closed. Well, guess what? They're all reopening now. Respiratory therapists are not always utilized in these areas, and that's another area where we could get goal number 1 to be a highlight of what we do. And so we would bring out the National Action Plan goal of number 1 if we did these simple things. Go on to goal number 2. Goal number 2 is to improve the diagnosis, prevention, treatment, and management of COPD by improving the quality of care delivered across the healthcare continuum. This is right in our wheelhouse, okay? This is stuff that we do every day, right? We promote the COPD assessment and treatment guidelines to healthcare professionals. We do that, okay? We incorporate COPD detection, care, and treatment recommendations into our clinical settings. We identify opportunities to increase healthcare professional awareness and use existing COPD training tools and model programs, develop and offer culturally and linguistically appropriate patient resources, including, well, we already said that from number 1, but it is a carryover to goal number 2. Develop, support, and encourage participation in COPD training programs for healthcare professionals, particularly primary care practitioners. We can talk about that more in a second. Use medication reminders for COPD risk detection during patients' health care visits. Educate healthcare professionals about national COPD detection, treatment, and care guidelines, and ask healthcare professionals to assess patients for COPD, including the use of spirometry as appropriate, and then develop a personalized written or digital, if preferred, management plan. So yes, I created a slide, and let's talk about those. Give it a second here, a little slow coming up. So here are my examples of goal number 2, okay? RTs need to take a frontline stand, okay? We need to be the advocates that we are, okay? I can tell you right now that readmissions in many hospitals is under the contractual obligations of an outsourced company. There are many hospitals that are dealing with the readmission issue internally, but not as many hospitals as you would like have that led by respiratory therapists, okay? Utilizing protocols, treatment based on evidence and approved guidelines. How many of our hospitals use the guidelines? Now, if anybody has heard me speak, I talk about, unnecessary therapy. I speak of the Orange Regional Cocktail, that every patient who has a wheeze, and even if that wheeze is heard in their big toe, they will get the Orange Regional Cocktail. We're working to decrease that type of unnecessary care to make sure that we have the time to spend with the patients. How many of you are rank and file respiratory therapists that go out the door with 10, 20, 30 treatments that have to be done, and the only thing you can do each round is just get those treatments done? How many of you have said that? I want to spend more time educating my patients. Those are the huge part of things that we need to change, because we need to be those experts, and that's how we can use goal number 2. Your RT department, okay, or at minimum an RT, to get involved in primary care practices to raise awareness. Now, I know I'm taking Tim's job, but I just happen to see who pays for our services. There are opportunities for physicians to collect money for respiratory therapists doing this teaching in their office, okay? Respiratory therapists can't bill for their services in the physician office, but the physician can. So you could contract yourself as a service to that primary care office, or if they're really gung-ho on dealing with the problem, they may take you on as an employee. And these are just those opportunities that we need to seek to try to make sure that we meet things like goal number 2 to improve the diagnosis and treatment. How many of us have taken the time to speak to primary care physicians because we've seen their patients come to us and say, there's a better way to do this. Do you use spirometry? Now, I know spirometry is a tricky thing because anybody can do spirometry, but you could offer to them something simple as, my national professional organization has a spirometry course that a non-respiratory therapist can take to make sure that they're giving this spirometry the right way. Okay? Now that, again, you can get mad at me for saying allow other people to do things, but remember, we've got to insert our foot into these areas a little at a time. Okay? It gets tough after a while to hear people say that, a respiratory therapist costs me too much. Well, a respiratory therapist may cost you too much, but look at what you get from them. So a lot of this work has to be selling ourselves. And goal number 2 is a perfect example of one where a respiratory therapist can start to get involved in other arenas. We are so ingrained in the hospital, and that's one thing we as a national organization are trying to work on. We're trying to find other areas. But I digress. So let's go on to goal number 3. So goal number 3 is to collect, analyze, report, and disseminate COPD-related public health data that drives change and tracks progress. How many of us have part of our job is to collect data? You know what? If you're rank and file respiratory therapist, you may not, but I'll guarantee you that there's somebody who's looking at data on another side of the hospital that's trying to find out how many COPDers were admitted this month, and even better, how many of our COPDers are coming back less than 30 days. But that's the simple data. You know, we need to collect and analyze data on things that we're doing. I'm working on trying to bring a pulmonary rehab program in, and my senior administration asked the question, how will I know that the program is working? Well, you have to collect data. You bring patients into the program and they're successful, you're going to have to track them for 1, 2, 5, 10 years after to see what's going on. But all of this data that we can collect will help us be able to find opportunities to better how we handle the disease. So here is 8 different points of how to engage and participate in goal number 3. Report the prevalence of COPD in accordance with requirements of public health and healthcare organizations. Work with public health authorities. Use your electronic health record or public health record technology to assess and evaluate the capacity to monitor and control COPD-related services. Collect detailed information about population-specific health disparities in COPD prevention, diagnosis, care, and treatment. Promote research that tracks the prevalence and incidence of COPD, including phenotypes. I'll tell you, some of the research group talked about stuff that was way over my day-to-day knowledge, and I'll tell you that the research that's out there for COPD is starting to get voluminous. Continue to build existing COPD patient registries that help evaluate and improve patient management. So, you know, I kind of mentioned this before, and I'm going to use an example now. You know, I talked about a pulmonary rehab program. Well, pulmonary rehab, we know, helps with the readmission problem, helps with quality of life for our patients. Okay, so, you know, how do you track them after pulmonary rehab? You keep in contact with them. You know who went through your course, and if they're in the area, now if they leave the area, you're not going to be able to do this, but if they come back, okay, to your hospital, you have the data that they came back to the hospital. Well, hopefully before they got into your program, you know how many times they were admitted to the hospital before the program. Now you track them afterwards. Hopefully a good outcome is that after pulmonary rehab, their number of admissions goes down. Surveillance project and epidemiological investigations to understand the characteristics and needs of people at risk for and living with COPD. I got a good one for that. We're going to go to the next slide soon. And create a common portal database, make its use publicly accessible in order to evaluate and enable predictive monitoring. So here's some things that you may or may not know about. I know that we as an organization are trying to work with state liaisons to get certain questions added to their respiratory health module, which will capture COPD-specific information. Right now, I believe only 8 or 9 states are doing it, but we have 50 states in this union and other outlying territories. It should be on all of them. Work with hospitals that get data out of the EMR to create opportunities to show the scope of the problem in a community at large. You know, there's a lot of data out there that could be made available. Problem is, a lot of people think of this stuff as it's proprietary. at some point in time, we've got to get beyond the proprietariness of our data, and not to break HIPAA, but we need to know our community. We need to know what's going on in order to help them. So let's get to goal number 4, increase and sustain research to better understanding the prevention, pathogenesis, diagnosis, treatment, and management of COPD. This one's pretty straightforward, and I'm not reading all of those, okay? But I can tell you the research part of this interests me. Now, I'm not a researcher, and I'm sure there's many of you that out there that are, but we need to dump more money into finding out not only how to treat the disease, but maybe even find out the epidemiological issues. You know, you can talk about different areas. You know, there's certain areas of the country where smoking is high. And you know, there's a lot of COPD, and you sit there and you're banging your head against the wall because you feel like you're talking to the wall. You know, there's other sections of the country that you would look at it and you do research and you find out, wow, I didn't think that they would have a high level of COPD. Now, I know this isn't COPD, but you know, I live in the state of Connecticut, but we know that in the I-95 corridor between Bridgeport and New Haven, even in Stamford, that there's high levels of asthma. And the only way you find out this data is the research and the projects that help you gather this data. So we need to find more ways to do this. So one of the things that I know a lot of my good friends in research, we don't do a good job getting our respiratory therapists ready to become researchers. And you know, as we talk about advancing the profession, we need more respiratory therapists out there to engage in research. That means that we have to educate ourselves better. We have to understand, and I'm going to shudder when I say this because when you say statistics, I go into little convulsions, but I got through statistics. We need respiratory therapists to be a part of this. Okay, because we need to research both the direct and indirect causes of COPD. And then there's goal number 5, translate national policy, educational, and program recommendations into research and public health care actions. We need data. Okay, when we do something like bring out a part of the National Action Plan, we need to know that that part of the National Action Plan is working. Okay, we need to get data to show that, you know, goal number 5 seems to be out there quite a bit, and we have data to show goal number 5 is, you know, getting better. Well, goal number 5 is actually to measure the rest of the National Action Plan. So the question would be, how do we know 1 through 4 are being done? So we need to find ways to create quality control performance metrics. We got to adopt and use those metrics. And it has to be something that can be used globally. We can get statistics on a geographical basis, but in the end, if we can start looking at this as a global issue, I'm sure that we're going to come up with maybe some quicker resolutions. So if you come away from this presentation saying, damn it, I'm going to, yes, I just clapped my hands, sorry about that. I'm going to implement this National Action Plan. I'm going to my boss, or I'm the boss. I'm going to go to the boss's boss. I want to bring out parts of this National Action Plan. When you do that, when you enact parts of the National Action Plan, come up with some sort of an indicator to show that you're doing it, okay? I don't have answers for what. I mean, I gave you an example of if I start up a pulmonary rehab program, I'm going to take the patients that get readmitted the most who qualify for pulmonary rehab, and I'm going to bring them into my program. I'm going to have a wealth of data before they come into the program. After the program, I'm going to look at things like quality of life for them, number of admissions to the hospital, number of times that they utilize the doctor versus going to the ER. These are all data you can keep, and hopefully you can have some before statistics. But the whole goal is that when we go and use this, okay, we begin to use the National Action Plan, we need to be able to report back that not only are we using certain of the goals, but we're also seeing the certain results. So, dissemination and implementation of the COPD National Action Plan. I'm speaking to a respiratory therapy community because my goal here is to engage you to become a person or persons who will utilize the National Action Plan in your practice. So the goal here is to get the respiratory therapy community to understand that we own this plan and utilize it. But this is not just a respiratory therapy plan. Just double checking, do we have a problem with sound? I'll keep going.
No, you're good, Frank.
Okay, thank you.
You're good.
If it's okay, it might be just individual. I just want to double check that. So here's the key. I'm talking to you as respiratory therapists, but we need patients and their families. We need researchers. We need public interest organizations and advocacy groups. We need government agencies. We need professional societies. So the American Association for Respiratory Care is doing our part by talking to you today and engaging you about this. And then we need industry partners. We need everybody to take this National Action Plan and deal with it and work with it and use it. And let me show you this slide that was created by the NIH for us as part of the slide deck. So I just told you who are the owners of this plan. And so what we did was we made 5 boxes. And I'm going to assume that most of you are in the box that I circled, okay, that you're a health professional, okay? Because I'll tell you one thing. I'm an advocate, and yes, okay, advocate or nonprofit, AARC is a nonprofit. You'll notice that the lines will go to the same boxes. So for a health professional, goal 1, goal 2, and goal 5 are probably the ones that you're going to deal with the most. Okay, goal 1 and goal 2 are the ones you're going to put into action. And remember, goal 5 is the one that says that once we turn those recommendations into action, we need to follow up on them. We need to make sure that they're doing something. But if you're a person on here who is a patient, you're a family member, a caregiver, you can see that for you, 1 and 5 are the goals that you'll more likely use. So you can look at wherever you are on this list. If you're a researcher, okay, you're going to have the added benefit of having 3 and 4 as part of your timeline and goal number 5. But as you can see, there's a lot of paths towards using this goal. How can you promote the action plan? Well, like we're doing here, and I can't even begin to count the number of people on this webcast. I'm impressed. Help bringing the visibility of the action plan among, in this case, healthcare professionals, and we're doing that part. Well, now you are there, okay? You have seen the National Action Plan. You are now empowered to bring this to more people, more patients, more caregivers, more advocates in your area. The one thing I want you to know is, this slide deck, I will give credit to the NIH. I asked them about this slide deck, and it came out a week afterwards. This slide deck is actually available to you. If you go to copd.nih.gov, you can get pretty much most of the slides that I have on here. Now, I put some extras in. You can get the Outreach Toolkit. You can get videos and animations. There's social media resources. There's fact sheets. There's the executive summary. It's all there, okay? And you could look towards the professional organizations. The AARC has links to this as well. And by the virtue of us doing this webcast, we are doing our part as a professional association to get the word out there. But it's not just our association. You have associations like the COPD Foundation, the Alpha One Foundation, all of them who deal with COPD are a part of this. And I urge you to get involved. Because let's take this from being that Rodney Dangerfield of diseases, the disease that gets no respect, and move it to one of more knowledge, more treatment, and more understanding. And as I say and end every letter to my peers, I want to thank you on behalf of our patients and our profession for taking the time to listen to this today, because I believe this action plan is hugely important when it comes to our ability to care and advocate for our patients. And as I said, and I'm just before I turn it over to Tim here and we can go over the questions, copd.nih.gov, you have all of this there, or go to the AARC's website. There are links on there as well.
All right. Well, thank you, Frank, and you've carried us all the way through about 52 minutes, and we've got a lot of great questions. So if we can keep the answers as short as possible, I think we can probably get through some of these because there's some good ones out here. Let's start off with this one because I think it was a little bit of a misunderstanding about something that you stated. We get a question that comes in that says, who pays for our services in primary care, office, urgent care centers? I partner with another RT to bring education to patients in skilled rehab facilities to help them with their families manage the disease. Facilities don't want to pay for this service. There's another one that talks about their partner and them are RT-COP navigators, and they want to know how they can bill for their services because right now they can't do it in the hospital setting. So you may want to go back and reiterate what incident to physician services means and how those are reimbursed.
Yeah, so there's two sides here. The outside of the hospital, there is, and even inside the hospital, there is no reimbursement for a respiratory therapist per se. There is reimbursement, though, for certain services where there are CPT codes. The doctor's office can bill for them as incident 2. So they only get a percentage of what they would get if they do this for themselves. Now, the big part of it is, are they going to get enough reimbursement to pay for your services? Are they going to pass that through to you, or are you going to contract with them? That's a totally different topic for another day. But even in the hospital, a lot of the education we do is not paid for. But again, you have to find ways to show that the service you're providing is somehow positively impacting the outcomes of the patients. Maybe your readmission rate has gone down from 20% to 14%. You might be able to quantify that in dollars. So no, there is no direct payment per se. Tim, did I get that?
So I think what you're So what you're talking about is under Medicare Part B, which is the doc reimbursement part. There is no direct CPT codes or reimbursement to respiratory therapists. It's always covered, probably about 80% under a Medicare Part B physician services is what you're getting at. There's also a question out there about how do we kind of get more information, and what we will do is to not try to answer that and belabor the point is we'll get you guys a link to a spot on our advocacy page on our website where Anne-Marie Hummel, who is our regulatory person, can actually give you guys a toolbox that she's provided out there on how to do these incident to physician services. Looks like we have time for a couple more, Frank. So here's a good one because I think it's exactly what the purpose of this program today is. I'm attending a meeting regarding COPD National Action Plan with the Department of Health in Kentucky, representing RT and knowing what we all touch in COPD care. How best should I approach the meeting? What types of things should I go in there with and prepared to do?
Wow, that's a good one. And I'm trying to find it, but the screen keeps blinking on me here. So you need to first approach the meeting with how are they presenting it, but representing the therapists, and you need to go back to the plan. Go to the National Action Plan again, and I saw other people, how could I get this? I think I put it copd.nih.gov, and Tim said it'll come up there. Look at the action plan, and for you as a respiratory therapist, I would probably start off with goal 1 and goal 2. Get to know goal 1 and goal 2, the empowering people with COPD and improving the diagnosis, and come at it from that approach when you go to that meeting. Don't expect to have everything click all at once. Take little bites out of it and go over how a respiratory therapist can impact goal 1 and goal 2. That will show them that you understand about the National Action Plan and are starting to integrate that into what respiratory therapists can do. I don't know if that was enough. I see that question came from Kyle. Kyle, I can talk to you offline too, because I'm sure that the explanation goes well more than probably the 2 minutes we have left. So Tim fell off. That's what happens when they live in Ohio. No, only kidding. I'm just upset because Cleveland beat the Yankees 3 games, so sorry about that. Let's look at question. If we need more respiratory care therapists doing research, is there opportunity for online training via the ARC that is cheaper than what is available now? Some therapists cannot purchase these courses at high cost. The ARC is working with the research community to try to find ways to get more people involved in research, but a lot of times the research that needs to be done is you need the education behind it, and sometimes it's not just a online course. So I don't have a good answer for that, but if we do have other ways, Sherry, we will try to get back to you on that, on an offline answer. One thing that I noticed, I'm hoping I answered the questions about data. QC performance metrics, there's not a lot out there. We're going to end up having to create them, but as a professional organization and as a profession, we should help doing that. Tim, did you come back?
I am back.
I tried my filler.
Yeah. So I apologize for that, folks. I lost my connection, and Frank, it looks like we're right up against the hour, and what we have typically done is that we have saved these questions, and what we do is go back out and put them on ARC Connect to try to get the questions that we weren't able to cover in the 60 minutes along with the presentation. So at this point in time, Frank, I want to thank you again for joining us today, and ask everybody that's sitting out there in the audience to please join us for the next webcast on Friday, September 22nd for the Respiratory Care Journalcast, and the September's Editor's Choice with Dr. Doug Gardenhire, and again on Friday, October 20th for the October Editor's Choice with Miss Kathleen Deacons. And before we go, there is an added bonus today that I want to touch upon for everybody. Many of you are aware of our current topics in respiratory care DVD series. It's a series of 8 educational DVDs that we provide at a low cost to try to get your departments educated. And we have one of those upcoming current topics towards the end of the year, the future of mechanical ventilation for ARDS, and I believe Dr. Eddie Pan is the person who provided this DVD education component for us on this last year at ARC Congress. And Dreger Medical sponsored that. And what they've said that they would do is today that they would actually offer a complimentary copy of this to folks that are on today's webcast that are part of the management section. And what we'll do is we'll just do a blind raffle of everybody on the webcast today that belongs to the management section. We'll get a winner. We'll reach out to you and contact you that you are the winner of that Current Topics DVD program, and we'll get the information out to you for you to help educate your staff on yet another topic. So with that being said, I want to thank everybody out there for joining us, and have a great day.
Excellent. I think that's all the time we have for today. Thank you to Frank for sharing his expertise, as well as Tim. And thank you to our participants for extra interesting questions. In just a moment, you'll see a Submit Credit button on your screen. If you are an individual who's registered for this program, you'll go through the credit submission process on your individual account. Should this button not appear, please navigate to the Credit tab to select the Click Here button linked. If you are a group participant, please have your group leader submit your information to the Group Attendance tab to be provided with follow-up instructions on how to submit for credit. This concludes today's presentation. To end, simply exit out of your browser window. We hope you have a great afternoon.